So that was a very exhaustive and very nice presentation by Dr. Ashok Seth. And of course, there's so many learning points we could get from that presentation. And now I move to this presentation on complications. So I mean, as you can understand, that complications, are so many types of complications. And, in 10 minutes, I won't be able to take you through all of them in detail, but certainly I'll give you a snapshot of what one can expect and how to handle some of these complications. Because the technology is new and we are recognizing these complications slowly, and of course the pathology and the appearance, everything is new. So we'll have to look at these ones which have already been seen by our colleagues and try to make a note of that when these things happen. So what are the kind of complications which one can have? One is the procedural complications in terms of occurrence of paravalvular or valvular leaks. Then, of course, renal injury can happen because you are doing a procedure with sometimes too much contrast, dissection of the aorta, vascular complications, coronary occlusion, and of course, pacemaker implantation, which I don't think is a complication. Then, early post-TAVR complications can happen, which is embolization, TAVR embolization or migration, I must say, TIAs, periprosthetic leaks, patient prosthesis mismatch, which Dr. Seth also mentioned in his talk. When the valves are small, we have to look at those things. And then, of course, injury to the aortic annulus, and of course, aortic dissection, mitral valve dysfunction, and tamponade sometimes. So sometimes there can be some late complications, and one Dr. Singatwale already mentioned is a late coronary occlusion, which has been now increasingly being recognized. Then TAVR migration can happen, and there have been cases where valve migrated once the patient was shifted back into the ICU or back into the ward 24 hours later also, but that is not so common. And then persistent paravalvular leaks is another big thing which we still are trying to grapple with, and of course many ways of handling this problem have emerged already. So let me take you through this one by one. And of course the most easy and important way to find this is to keep doing the echoes in these patients. One is echo in the cath lab itself. So we need to have a good echo person in the cath lab to give us both the occurrence of leaks, the depth of the valve, and also the occurrence of and the gradients post valve implantation. Because post valve implantation gradients are very predictive, and we have to look at these two factors very importantly: the gradients and the leaks, which are residual when the valves are being implanted. So how do we do that? We keep looking at the hemodynamics, which could be basically on the catheter, which is on in hemodynamic assessment. And then the second is echo, which is done either transthoracic or transesophageal echo. So this is the way to do that. And of course, looking at occurrence of mitral valve regurgitation during the procedure is also a very important thing which one has to look for. So valve positioning is one of the very important things which is to be considered to prevent these complications of coronary obstruction, and then of course occurrence of mitral valve regurgitation and paravalvular leaks, as you already saw in some of these presentations, that when valve is not well positioned, it can jump out, as Sai very, very nicely showed in his case, which he also managed very effectively. And then, of course, there is a way to assess these things, and one of them is to do a hemodynamic assessment of making an aortic regurgitation index in these patients, and also calculating the effective orifice areas when the valves are being implanted. So whenever the gradients are high, and of course we have to also keep in mind the patient size, and the third is the size of the valve which you are implanting inside. So AR index is a good indicator, and one must keep that in mind. Also, keeping a watch on the diastolic pressures during the procedure is an important way to keep a track of valvular regurgitations. Then valve embolizations, as you can see here, that the valve in one patient it is already very high up, and in another patient it actually embolizes either into the ventricle. However, the most common place for the valve embolization to happen is with the balloon expandable valve is the ventricle, because the whole column pushes the valve down if it is not implanted well or the size is not adequate. Then these migrations can be assessed by echocardiographic examination, and hemodynamically if the patient becomes very unwell, start looking at these things and immediately be concerned about it. Valve thrombosis can happen early and can also happen late. And how do we know this? It is known by sudden increase in gradients, and then subsequently watching it on the echo if there is obvious thrombus or restricted opening of the valve. And also one can do a CT examination in these patients to find out if the thrombus is sitting on one of these valve leaflets which is not moving adequately. And this is another new concept of neosinus playing an important role in leaflet thrombosis, which is now being discussed and leading to more occurrence of cerebrovascular events. So that is something, which is, it is being discussed that probably this will be lesser in patients who have self-expanding valves. Then, patient prosthesis mismatch is something which one has to keep in mind, although initially we were not too much concerned, but now with the lesser size of the valves and lesser, body weight and height, these patients can have a patient prosthesis mismatch. So we have to try to give as big a valve as much as possible, and we don't repeat the same mistakes as were done by our surgical colleagues in the past. Then transient mitral regurgitation can happen because of guide wire interference, and we have seen severe mitral regurgitation happening because of the wire loop which is into the ventricle and leading to transient MR, which if detected in time, and of course we can handle that wire position to see if it can get corrected, and once the wire is removed it is fine. So doing a TE at that time is quite helpful. And then of course a very low position of the valve can also lead to occurrence of a mitral regurgitation, which needs to be addressed. Occurrence of annular rupture and hematoma is also a serious complication which can be assessed by a good TE examination can quickly tell us while the patient procedure is being done. Then effusion and tamponade can also happen in some patients because of the wire, because of malhandling. And so once the echo is there inside the lab, it is very easy to quickly find out and do the pericardiocentesis and treat it. A four-dimensional CT is being now increasingly used for the detection of abnormal leaflet thrombosis. So now quickly let me take you to some of my experiences. And here you see a patient where the valve was, it was a very initial experience, but it was a bicuspid valve with one of the largest annulus, and the biggest valve which was available at that time was a 31. And when we started releasing the valve, you can see the valve is almost 80% done and it is not expanded. So this was something which was very, very, horrifying to us. And this is a core valve which cannot be repositioned. So what do? So we pulled it back into the descending aorta and left it there, released it there. Here you can see that we are pulling it out, because if you release it here, then it becomes a little bit of a problem, because it can pop out at that time and then it will be very difficult. So we pulled it back and then left it in the aorta, took a second valve, and then we released it in a proper position. And you can see that there is the valve is not fully expanded. So we did a balloon dilatation and got a good result. Patient was fine for 5 years. And then he developed an episode of endocarditis. Following this, he had transvalvular aortic regurgitation because the leaflet had degenerated. So what we did was, in this patient, when he was fully done, about 6 months post-infective endocarditis, no evidence of infection left, then he was taken for another valve-in-valve implantation. You can see here, we do another valve. Now this is a evolutar, which was done. And after that, this is the third valve in this patient, I must say. and the patient is doing very fine, no AR, and did quite well after that. And his weight is still going up and down. It is above 116 kilograms. So another case where there is a valve embolization, and this is a Hydra valve, which we are doing here. You can see that the valve is being released in this, again, post-CABG patient. And you can see that this valve, although is repositionable, was in a good position to start with. And while we released it somehow, the release completely didn't happen with the second, hook there, and the valve jumped out. So we had to obviously pull it out a little bit back, as Satish already showed, above the coronaries, hold it there, and put a second valve inside. And the first valve was left into the aortic root above the coronary ostium, so that it doesn't block the coronaries, making a tube inside. So this is a valve-in-valve for a opt-out valve. And then, of course, many times we have, when we implant the valve, I'll quickly show you that this is another big valve. And in here, very heavily calcified. This is a 34 millimeter valve, which is being released in a post-transplant patient. And this is, we'll go through this. And here again, you see that this is a bicuspid valve. The valve is not getting, despite the balloon dilatation, the valve is not completely expanding. So we did a balloon dilatation after this, and found that there was some moderate insufficiency still left. Did some more dilatation with the balloon, with a bigger balloon, and the gradient was 9. My PVL became mild, so we said, okay, let us leave it there. And then patient was doing fine. We did a CT also, and we saw that this chunk of calcium was actually constraining the valve, and so that the valve, he was having that leak from the side. So the patient, regurgitation was persisting. Initially, it was mild, but then we kept assessing. It was moderate at some points in time, and he was having signs of fluid overload, probably partly because of the failing renal transplant also. So we decided to do a device closure of this PVL. So this is another way of treating this paravalvular leaks. So we tried doing that, but we could not put a big device. A small device would go in, a big device would not. So we left it behind, said no point in leaving a small device. So a patient still, was left on medical therapy, was not doing too well. So he still had symptoms. So we brought him back thinking that we'll do a balloon dilatation. If the valve does well, good. If not, then we'll put a balloon expandable valve. So we did the balloon dilatation, and then valve leakage was still there. So we thought, let us put a S3 valve here, which would probably lead to the complete closure of the PVL. But unfortunately, even after the valve, implantation, which was complete full expansion, there was a leak which was persisting. So we said, no, this is the time which we have to do all the things whatever possible. So we did the device closure of this PVL which was persisting, and we put this device inside. But when we put the device inside, part of that device was actually hitting the leaflet of the valve inside and led to severe valvular regurgitation. So then we put another valve because there was no other way. So we put another valve-in-valve. The third valve was taken inside, which is a self-expanding evolute R valve, which was I think a 29 size valve. And after that, the PVL became very mild, and then we left the patient on that. So these are the complications which can happen in patients. And of course, the commonest thing which we do to treat the PVL. PVL is the most troublesome thing. We do a post-dilatation. If it doesn't help, this was unique that we had to use 2 balloons to dilate it. This is a big balloon. Despite that, it was still there. So we did a double balloon dilatation in this patient, which was another new thing which we did on our own, not realizing that it can sometimes lead to complications. But in this patient, it helped, and the valve regurgitation became very mild. And this patient is still doing very well. So various ways. And here you see that the patient is being taken for a routine, valve implantation. And in here, after the wire was put in, the patient started having regurgitation. And when the device was inside, the AR became even severe. And the patient suddenly started deteriorating. So we had to pull everything out. And in that, even the wire came out. And when the patient was not doing well, we thought that let's put the wire out also, because it's all because of AR. You can see the AR was so severe. So then we put this patient, because the patient deteriorated badly, put on ECMO. And once the patient was on ECMO, we did this valve implantation on ECMO, and then the patient started recovering. So occurrence of severe AR during the procedure is quite a serious complication, and that has to be immediately dealt with. Otherwise, the patients crash quite badly. Here, this is our first transcable case, and in here the problem happened at the site of the access from the IVC to the aorta. Everything went off very well. And here you see that this is the puncture which we are doing from the IVC to the aorta. Everything was okay. And then, we implanted this, this is a MyVal, I think. Yeah, this is a MyVal. And we also did a coronary protection. And here you will see that the coronary ostium height was 6. And we knew that there will be a very high chance of having this, occurrence of stenosis in this left main, which happened. And we did a chimney for stenting from the ostium at the LAD, and that also worked very well. But while we were pulling out the sheath with the ADO8 occluder, the occluder jumped out. But at the same time, we had another stent in position, because that was our contingency. In case it happens, we'll leave the stent. So the patient immediately started crashing, but we had the stent there. So within no time, we released the stent and got quite a clean result, as you can see here, and everything was fine. So we have to be ready in these situations. I think, with this, I will this will be the last case I'm going to show you, that sometimes the valve is not crossing. And this is a MyVal. We are trying to cross. We did the pre-dilatation. In a bicuspid valve, we always pre-dilate, but still it was not going. So we changed the wire. And here you see that we took another buddy wire. Still it was not going. We changed to Linderquist wire. Still it was not going. So then we took a balloon to track it. So we did the balloon dilatation. It was not going. So we took a smaller balloon at the valve. You see the small balloon, which is being inflated, and on the other wire. And then after that, the valve was taken inside. And once this was done, we are seeing that it is quite well in position. So I think, with this, I will stop here, because these are so many complications, either small or big, can happen, and we have to treat them as soon as possible. So thank you very much for everybody's attention, and I'm sure we'll have many more cases in this session.
Praveen, thank you very much for your nice presentation. You showed most of the complications, I'll be put 3 valves in one case. Do you change the post management to start anticoagulant and all this, where you use multiple valves?
Okay, so in these 2 patients where I showed that we did 3 valves.
2 and 3.
Yeah. So we didn't do, we did the same thing. We did the dual antiplatelet for these 3 months, first 3 months, and then followed by a single antiplatelet. And this almost more than 2 years, 2.5 years since the valve implantation in this patient, and he's fine. However, in smaller valves, where we put 20 or 23 and the gradients are slightly high, or if the gradients go up, then we put them on either one of the newer anticoagulants or oral anticoagulation therapy in association with aspirin.
Experience, you had any annular rupture?
Dr. Rath, can we move on, because we are nearly 40 minutes behind.
Yeah, fine. Go ahead.
And we've only had 4 speakers, and you're already at 5:20, and there are 6 more speakers to go.
Go ahead.
7 more speakers to go. So I think we should really move. Bicuspid aortic valve and TAVR to treat or not, Dr. Ajay Swami.